Medurstand. Understanding medicine.
Professor Aziz Rehman from Medurstand. After inspection of the precordium, we are going to do the palpation. And I think in a normal examination sequence, we always do first inspection and then palpation. I believe it's human nature also. Whatever you see, you then tend to touch it and feel it, and how does it feel. So I'm going to do the palpation part. So we have already done inspection. I think I would start by touching my hand here in this patient, in this position. It could be this, the palpation of precordium can be very easily done in a sitting position, but it can be done when patient is lying down. Depending upon if patient is admitted in the hospital, already in the hospital bed, then you will do it in the lying down position, supine position. But if patient comes to your OPD clinic, then you will have to do it on while patient is sitting. So I will just touch his precordium like this and try to feel the apex beat. Apex beat, by the way, definition wise, is the lowermost and the lateralmost part of the precordium where you can feel the distinct pulse, the impulse. So that actually defines the anatomical position of the apex. So first of all, put your hand like this and you may be able to feel the pulse somewhere, and then you may be able to feel the apex beat somewhere. Suppose it is here, then with the help of a finger you precisely locate it. So I think yes, this is the part of the precordium where I can feel the pulsations. So then I will keep my finger here, and with the other hand I will count this intercostal space. Moving my finger from above downward, this is the angle of Louis. Second intercostal space, second rib, second intercostal space, third intercostal space, fourth intercostal space, and then fifth intercostal space. So it is in the fifth intercostal space. Then in reference to the vertical lines, if I draw mid-clavicle line here, it falls on or slightly medial to the mid-clavicle line. So as far as its location is concerned, it is normal. Apex beat is palpable, in this case fifth intercostal space, just medial to mid-clavicular line. And second thing in apex beat we notice is its character. It could be normal, or it could be what we call tapping apex beat, which is actually a loud palpable first sound, or it could be heaving. So heaving is when you actually feel the lift, like here, like this, not of course this much. You will feel as if your hand gets lifted with every apex beat. So if that is the case, we will describe it as heaving apex beat. Heaving apex beat could be sustained heaving beat, or it could be ill sustained, and the names are self-explanatory. Sustained means when your hand is lifted and it's kept there for 2 milliseconds and then goes away. And this will happen when there is left ventricular outflow obstruction, like aortic stenosis. Or it could be ill sustained heave. That means your hand is lifted and then it let go. And that happens in aortic regurgitation and in mitral regurgitation, and in also in hyperdynamic state. So accordingly we built the differential diagnosis. As far as its location is concerned, this apex beat could deviate to right or could deviate to the left. And in either case, there could be cardiac cause or there could be pulmonary cause. So if you've already done the pulmonary examination, then you would know if there is any possibility of pulmonary cause. Otherwise, you will build your differential diagnosis. So let's first talk about the heart. If there is dextrocardia, apex beat may be deviated to the right. And if there is right ventricular hypertrophy, when right ventricular hypertrophy, it simply pushes left ventricle leftward. So the the apex beat will move to the left, maybe, but will stay in the fifth intercostal space. It will move to the left side of the mid-clavicle line. So that is what happens in right ventricular hypertrophy. In left ventricular hypertrophy and dilatation, the apex beat moves actually downward and laterally, like this. It might go into 6th or 7th intercostal space, and it may coincide with the anteriorly axillary line or mid-axillary line, depending upon the level of cardiomegaly. So this is the cardiac causes. In pulmonary causes, you know, heart is in the center of two lungs. If there is a problem with the lungs, particularly in one side, and particularly if the disease is the type where there is either loss of volume or addition of volume, the heart will be pulled toward that side. For example, on this side, if there is collapse, atelectasis, or if there is massive fibrosis, it will reduce the volume and it will pull the whole the precordium, this heart on this side. So apex beat will move this way. So apex beat is pulled toward the disease side. Another example, if there is something which leads to increased volume, like pneumothorax or like big pleural effusion, it will simply push the precordium, the heart to the left side, and apex beat will move to the left side. So you can say the apex beat is actually pushed to the opposite side. So a one-sided lung disease where there is loss of volume or gain of volume can pull or push the apex beat accordingly, and you develop the differential diagnosis. You of course cannot make a final diagnosis on one finding. You will then relate it with the pulmonary finding and then finally make a judgment. Similarly, the opposite thing can happen on the other side. So this was apex beat, but there's another term we use in cardiology, that is cardiac impulse. Especially the American literature they uses. Cardiac impulse is any pulsation. You put your hand here and here also, and any abnormal pulsation, including apex beat, the right ventricular heave, or if there is any thrill is actually a palpable murmur. So if there is any abnormal pulsation, thrill, anywhere in the precordium, that would be included in cardiac impulse. So cardiac impulse is a more thorough finding, and out of that mostly we talk about the apex beat. So when we examine apex beat, to sum up, we first of all locate it, and then we see if it is deviated. We develop differential diagnosis. We find a cardiac cause or a pulmonary cause, and then we also study the character of apex beat, and then we see if it is tapping or heaving. That can lead to certain important valvular disorders. So I think this is very important, but of course nowadays we are more and more dependent on imaging tests. Probably that is why the clinical methods are losing their importance, but I think if you know the method, it is very, very important. It is extremely rewarding experience to make a clinical diagnosis which is later confirmed on imaging. Thank you.